Hi everyone, welcome for another VMR. My name is Marcela. I'm very excited because today I will be discussing with Javi. It's always a big challenge, but it's always a lot of learning, so that's very good. And we will love if you have a case for us.
Hello, everyone. It's so nice to see you. I have the distinct pleasure of hanging out with Marcela twice in 24 hours. So very lucky to be here and to hang out with you all, and especially with her. Does anyone have a case? Mukund, by the way, thank you for being very wise about when I heard from Maddie that you were popping on a little late. It's very smart for you to bypass the banter and jump straight to the action. And hopefully there'll be somebody who is here today who has a case to present. I do want to acknowledge how awesome it is for those of you who are joining us today and turning your videos on. Adam, it's great to see you. Rodrigue, hello. And Aaron, thank you for turning your video on. It's so nice to meet you. I know Adam very well. I've also met Rodrigue. Aaron, do you have a minute to tell us a little bit about yourself?
Sure. I'm a first-year med student at OHSU in Portland, and I used to be a nurse. So,
wow.
Yeah, worked in inpatient oncology and then switched to med school.
That's so cool. Inpatient onc, huh?
Yep.
Gosh, I feel like that experience must be serving you so well right now.
I think so. I don't know how much it helps with the biochem fundamental aspect,
yeah,
but
true that.
It's all right. Gives me
you forget about it eventually. I'm clueless, utterly. Alrighty, well, I don't think anybody is itching to have a case to present today, so I'll lean on our dear friend Leah, who discussed last week, to present a case to us. Go for it, my friend.
All right. So the case that I will present is a case report that I read, and it's a 35-year-old female patient with a history of 2 years of itch. Do you want some more information, or you want to discuss the chief complaint?
2 years of itching. Oh, that sounds miserable.
Oh
Marcela, what's going on?
Yeah, so that's a big challenge for me, like itching. Okay, if it was acute, maybe I can think about some things, but it's such a chronic itching for her. So I can see that she's a young female. So what came to my mind is that since she has been having this itching for such a long period, it must not be so aggressive, so severe, because I cannot imagine someone itching for 2 years, but like really itching and don't look for a doctor, you know? So I'm thinking that maybe it's something that is not so progressive, that comes and goes. So maybe an allergic process, or some process that we have when we have, for example, mastocytosis, that you release histamine, you have a lot of itching. And I would like to know more the relation between the itching and maybe some, for example, shower or physical activity or something like that.
Absolutely superb, Marcela. You predicted, based on the time course, the morbidity of the disease, saying that it's been so long. So the chances that it is morbid is low. And the other question is, what are the chances that you think she has a rash?
I think probably a low chance that's like a primary rash causing the itching, but maybe she has something secondary, like she's itching so much that now you can see in her skin a rash.
100%. The chances of her not having something on her skin is very low. And we'll have to answer a very important question. Is this a rash that is itchy? Or is it an itch that rashes? And that's very hard to tease out, very, very hard. So I think we can anticipate a rash. And the hard part will be, is it the rash that's causing an itch? Or is it an itch that's causing the rash? And we'll have to see. All right, Leah, tell us more.
Okay, so some more information on the patient. So the patient was known to have had bed bugs a while ago, but a professional exterminator came to remove them, but the itch still persisted. And she has no past medical history, no current treatment that she's on. The only thing they found was an elevated IgE, which was around 270, where the normal is below 100. But the physical exam at that time was normal, chest x-ray was normal as well. And they tried antihistamines, phototherapy, topical steroids, and tricyclic antidepressants, but there was no improvement of the itch. And now 14 months, like after the beginning of the itching, papulonodular lesions developed. And I will share an image, or you can say if you want to discuss this now, but I could share an image and then you could discuss it together with the information. And I would share the screen. Okay, let me know if you can see my screen now. And now these are not the images from the patient, but this is just examples of the lesions this patient had.
Wow. So intriguing. Marcella, what do you
Yeah, so that's very challenging for me. I have to say that dermatology is it's like a weakness, but I can see that like we were suspecting, probably the patient has a primary lesion in the skin. From the pictures, it doesn't look like just from the itching. And like I could see that she has these papules, maybe like Yasmin said in the chat, if it's umbilicated or not. But it's so chronic that I'm thinking about something more like autoimmune or malignancy or something related to that.
Yeah, no, Marcella, I too am struggling. I think that solving a case that has 2 years of itching and then the development of a rash is hard. And the rash is very interesting. There are people in the chat, Yasmin and Vale are both pointing out that the rash looks umbilicated and maybe suggestive of some specific disease processes. I think we can say with reasonable confidence, though not perfect, that the rash is not from itching. Um, it does not look like it, though prurigo nodularis, or the rash that develops from itching, can become nodular. So what I would be most interested in is to see if this rash is not in any areas that the patient cannot reach. So I quickly looked and saw that everything that we were able to see is in an area that his nails have access to. So I think that's going to be a key part. And Leah, I know because these pictures were not from the patient. Do you have a sense of that assessment? Are there any lesions in the mid back or the lower back where he can't reach or she can't reach? Do you know?
Um, it is a good question. I think there could be also in areas where she doesn't reach, but I'm not 100% sure. But it's
Gotcha.
symmetrically distributed on the body.
Gotcha. Yeah, that's very tricky. And so I think that, Marcella, we did get this phenotype that there's IgE elevation going on. So some sort of atopic disease process or allergic disease process. I don't have a clarity about how to get to the bottom of this. And then what I'm most interested in is somebody much smarter than me analyzing this rash beyond the basic level of, is it accessible to the patient or not? And I'd be curious to see if there's a visceral signature to this disease process in the internal organs to give us a clue. Bed bugs are often associated with other exposures like mites, and mites can also cause a chronic atopic issue. So I'm lost here. And I'm looking for guidance from the distribution of the rash and the basic labs to see if they can give us a clue. If the labs are uninformative, there's no way I can solve this case without the help of a dermatologist. So we're really relying heavily on there being an internal medicine dimension. If there isn't, then I think that we'll have to learn a lot. Sammy is mentioning a very important disease called Dagos disease, otherwise known as malignant atrophic papulosis, which is definitely an internal medicine condition. So hopefully the laboratory or abdominal signature of that disease will show up. All right, Leah, Mike, back to you.
Something for the review of symptoms that I forgot to mention in the beginning was that this patient, or actually, it's good that I'm mentioning it now because she presents again 6 months later, and now the itch has become really, really severe and is also associated with pain. But on the review of symptoms, there was no weight loss. And also, she said she didn't report any fever or night sweats, but she said she had this fatigue. And they did take a biopsy of these lesions, and the dermatologist said that it was consistent with prurigo nodularis, so what was mentioned before. And then they did start a treatment with dexamethasone because I presume because of the severity of the itch also. But with that, the symptoms only worsened, and she now had a palpable supraclavicular lymphadenopathy, so lymph node that was palpable there after the steroid therapy. And then with that, they did take labs. So now I'm going to.
Yeah, I'll say, I think you just gave us a lot of really important information that I think will be brief, but let's reflect on that. And then I think the labs will be, based on what you just said, I think the labs will be very helpful. Marcella, what thoughts crossed your mind? Because this case was very tense, but now there's some momentum somewhere. So what are you thinking?
Yeah, it's very complicated, but right now I'm thinking that I don't know much about prurigo nodularis, but she got a treatment with dexamethasone, and then we saw a palpable supraclavicular lymphadenopathy. So I'm worried about malignancy, especially because we know that this region is high suspicion for maybe a lymphoma or even a gastric cancer or something related to that. So I would first maybe go to Google and see if we have some association with prurigo nodularis with some malignancy, or maybe if it was the treatment, the dexamethasone, that could be associated in some way. And let me see. Yeah, and maybe go for check the labs and maybe a biopsy for the supraclavicular nodule.
Superb, absolutely superb. Okay, everybody, I would love for you to pay attention to this conversation in the next that Marcel and I will have in the next 2 minutes, like laser sharp concentration, because this is the goal of CP solvers. The goal is for all of us to elevate our diagnostic skills to help our patients. And I'll tell you that Leah has told us the answer to this case now with over 90% clarity. And let me tell you how we can get there. 90%, never say 100%, always be humble. But when you learn medicine more and more, you can have a targeted workup for this patient. So Marcel, let's walk through this sequential. We now have proven that this rash is as a result of scratching. That's what prurigo nodularis is. So remember we said, is it a rash that is itchy or an itch that causes a rash because of scratching? The biopsy is characteristic of prurigo nodularis, which are these nodules. So now we know that this disease has no rash. It causes severe itching. And now the differential diagnosis of pruritus without a rash is extensive and includes inflammatory and non-inflammatory conditions. The non-inflammatory conditions are liver disease, kidney disease, thyroid issues, and pregnancy related, which would have easily been shown up by now because we know they did a workup enough to get an IgE level, right? You're not going to miss liver disease, kidney disease, and catch an IgE, sorry. The inflammatory diseases are some autoimmune diseases, usually scleroderma before there's fibrosis, some infections, namely Zika and angiostrondylos, but the biggest concern is cancer. And so you already, even before, even just with the pruritus, you have to think cancer, let alone when you have a pruritus and supraclavicular lymphadenopathy. Oy. So, Marcella, the only way we can make progress with understanding why this person might have cancer is to use her age. So, what kinds of cancers do you know of that are disproportionately affect young people, are more common in young people?
I know that we can have a types of lymphoma. I don't
Yes,
remember
exactly.
specifically how, but yeah.
Excellent. So there's lymphoma for sure. Any other cancers that you've seen in young people? To just make a list, a general schema.
I think for her, breast cancer can happen, but it's kind of
Yeah.
rare. But since it's so
Uh-huh.
common in women, I
Agreed.
would also be worried with
Yeah,
that.
100%.
And in this case, I think I would maybe gastric.
So let's make a list of just cancer in all comers, in everybody, regardless of gender or age or any, no filters. Okay. The most common: lung, breast, prostate, and gastrointestinal. I say gastrointestinal because colon and stomach, if you add in the world. Okay. Lung, breast, prostate, gastrointestinal. Most common. What if you strictly filter by age? The most common tumors in young people, not children, but young adults. Testicular cancer, the vast majority of testicular cancer is in young to middle-aged men. Melanoma, which does not respect anything, including age. And many kinds of lymphomas, leukemias, and sarcomas. Remember, we had a case of a sarcoma about 1 or 2 weeks ago, lung mass.
Oh, I think we lost Habi, right? It's just for me, or
No, I think we lost him.
yeah. Maybe we can wait some minutes, and if not, Leah can give us another aliquot.
Hello. I don't know where you lost
Oh,
me.
he's back.
Hello. You
Yeah,
know that
hello.
Cisco internet is plus minus. I don't know where you lost me, Marcella. Can you tell me where I stopped?
Sarcoma. I think it was sarcoma.
Okay, so that's the list of people, cancers in young people. And the question is, which of those cancers is most likely to cause, thank you, Alec, most commonly cause pruritus, Hodgkin's lymphoma, specifically Hodgkin's. Now, there's another clue, Marcella. Which of those cancers do you think can last for 2 years undetected? 2 years. Only Hodgkin's. Sarcoma, no chance. Other lymphomas, no chance. Melanoma, no chance. There are many indolent varieties of Hodgkin's lymphoma that can actually last for a long, long time. So I hope with these reps and this exposure, you can start to see how there are many unique pieces of this case. Pruritus without a rash, young person, long-standing symptoms. There's a 10% chance we are wrong, but this person has a very high chance of having Hodgkin's lymphoma. Why is that important? You need to jump right away to an excisional biopsy. Take it all out. No FNAs, no core needles. What this patient needs is an FNA. And what Alec just said, maybe you would not have given steroids if you could have had this thinking, because now the diagnostic yield is a little bit less. So yeah, I feel like I've spoken enough, but this is why we're all doing this. Is I didn't learn this from magic, you know? It's from doing these cases and being exposed to it. There are very unique features of this case. Long-standing disease, pruritus without a rash, young person, lymph node, very concerning. Now, Leah, your job is to humble me and prove us completely wrong so we learn even more. I hope it's the 10%. But any questions from anybody? Marcella, any questions from you before we move on? Because I realize I talk too much.
No, Happy, thank you so much. That was really beautiful, amazing.
All right, so for next, I'm gonna go continue with the labs. The IgE concentration was measured again, and it was still elevated with 130. The CRP was elevated also with 14. Upper limit would be 5. Leukocytes were 12, so also elevated, and the IgM was elevated as well. And that's all that I have for the labs. And they did some imaging for the chest X-ray. The chest X-ray showed a mediastinal paratracheal mass, and that was also confirmed then afterwards with a CT. And they also found mediastinal and hilar lymphadenopathy on the CT. And then I would stop here before the next aliquot reveals the diagnosis.
So what do you think, Marcella? Where are you at now?
I think the labs, they are just kind of confirming our hypothesis that we really need a biopsy and a high chance of being a lymphoma, especially because of this mass and more lymphadenopathy. And I believe that the labs they are not really supposed to be so alterated, it's more the imaging, right? But they kind of show a type of inflammation that's expected.
Amazing. And just to use this as an opportunity to practice, to arrive at lymphoma from a different direction, how do you approach when you hear Leah told us she has a mediastinal mass? What conditions do you think of in general when patients have a mediastinal mass? I know Maddie has a schema on this in her Gladwell's notebook that she put on Twitter. So that'll come in handy at some point for sure.
Yeah, I love Maddie schemas. I save it on my Glass House also. It's the T, the terrible lymphoma, the teratoma, the thyroid, and what was the other T? Sorry.
Thymoma.
Thymus. Yeah, thymoma.
Yeah.
Thank you.
Now ask yourself, Marcella, which one of those is associated with regional lymphadenopathy?
Yeah, that would be the terrible lymphoma.
Yeah. So from so many directions, this case is looking like a lymphoma, which means you need to have an excisional biopsy at the next step. And I think the indolent nature of it and the paraneoplastic pruritus is very suggestive of Hodgkin's in a young person. Yeah. Any other thoughts before we ask Leah to tell us what happened?
Not really, looking forward to see what Leah has
absolutely.
to reveal.
Let me just make one clarification that Alec is bringing up here. When we say teratoma, it's a reminder that it's any germ cell tumor, including testicular cancer. So the T's is a shortcut. Remember, teratoma is a little bit more complicated. Thank you, Alec, for bringing it up, because it is evocative of germ cell tumors, all of germ cell tumors, which may be teratoma or maybe non-teratomas. All right, Leah, Mike to you.
I loved your reflections on this. I think, yeah, they did some serology, so some tests also for infectious diseases. So they checked hepatitis, HIV, toxo, parvo, B19, syphilis, EBV, and TB was also brucella, bartonella, but these were all negative. And they did do lymph node biopsy, which showed Sternberg-Reed cells and some other markers that I don't really know how to interpret, but they were all consistent with the diagnosis of Hodgkin's lymphoma. So you were spot on with your thoughts also in the discussion. And then this patient received chemotherapy, and even after the first round of chemotherapy, the itch got better, the pain also resolved, and the lesions on the skin went back. So the diagnosis of this patient is the non-Hodgkin's lymphoma. And I have some, because also for me, this was a bit new and I haven't read much about it. But when I read the case today, the first thing also I checked is this prurigo nodularis. And it can have very many different etiologies. And many, like approximately half of the cases are because of atopic dermatitis. So actually a primary skin disease. But then systemic diseases could have it, like diabetes, chronic renal failure, hepatitis C, HIV infection is also quite a relatively common cause. That's why it's important to do the test for HIV as well. And then, yeah, so you basically had really early on this focus on these unique features that then pointed to the Hodgkin's lymphoma.
Yeah, thank you so much for bringing such an incredibly educational case to us. I think that the truth is it was a very tricky one to get to the bottom of. If you watch the tape again, like we were incredibly lost. But as soon as you put the words fatigue and prurigo nodularis, the case gets a lot of momentum. But it's amazing how you can go from utter confusion to more clarity with small things in this case. And I'll pass the mic for Marcella to hear her reflection on a very complicated case. But how humbling is medicine when a patient comes in with, I'm 35 and I've had 2 years of itching, and you learn that she needs chemotherapy. So our journey towards achieving what we want to do for our patients is endless and limitless. And I really appreciate all of you for taking the time here to spend the extra 30 minutes of your time to do that. This is a donation of your time to your own skills and your patients, and really, really appreciate that. But it's a special donation, honestly, to the people who are making it happen. Leah for presenting a case, for Sammy for scribing, for McClune for the teaching points, and for Marcella for being the most vulnerable of all, putting her thought process in a complicated case out there on YouTube. So thank you, Marcella. I'm curious what your reflections are.
Yeah, thank you so much, Javi, and thank you so much, Leah. That was such a powerful and humbling case, because it showed me first, I think, the importance to ask why. Why is this patient itching for 2 years, and what is happening here? It has to be an answer, and also to see how much I need to study, but also practice. Like Javi showed us, you need to practice, keep practicing, so you can get this ability of clinical reasoning that you are not going to get in the books. So thank you so much. That was incredible.
Mukund, thank you for being here. My delay in unmuting was because Sammy just private messaged me saying, I love how Marcella pronounces your name. And I literally told her that yesterday. I wish all of you would pronounce it the same way she does. It makes it sound so much cooler than it actually is. Anyway, Mukund, take us home, please.
Sure. I totally agree with Marcella. Dermatology is a weak point for me. So when I saw a derm chief complaint, I was like, oh my God, what's going to happen today? And I think I anchored really early on a primary derm concern in my own head. So this was a complete twist of events, and I'm really happy that I was here for it. So let's go through the teaching points. Pretty straightforward flow of things once we got started. And I learned a lot personally. So we started with a chief complaint of itching, which is kind of the most general chief complaint of all time. And the way we decided to break it down is it a rash that's itchy, or is it an itch that rashes? And in particular, we talked about using the physical them to discover if there are parts of the rash that are present in places the patient cannot reach, and that will help you decide whether it's a rash that itches or an itch that rashes. After the biopsy findings, though, this case got a lot more interesting. Prurigo nodularis is something that I learned about today for the first time. These firm dome-shaped nodules that are non-hereditary, non-contagious, with an unclear pathogenesis, but with a variety of etiologies, which we'll talk about, that arise as a result of scratching for a prolonged period of time. They're closely associated with atopic conditions, such as atopic dermatitis, and other inflammatory conditions, infections, and notably cancer, which in this case was the cause, as well as other non-inflammatory conditions such as diabetes, liver and kidney disease that were ruled out by previous providers. We moved on to a discussion of cancers, and this was a really awesome epidemiologic way of approaching the problem, which I thought was really cool. Starting with the discussion of cancers by incidence in all ages, from most to least common, and moving on to cancers by incidence in young adults, testicular, melanoma, lymphoma, leukemia, and sarcomas. And of this list, we found that there was only really one possibility that could cause these symptoms and was indolent enough to cause them for 2 whole years. That's Hodgkin's lymphoma. A biopsy, of course, gave us the diagnosis with the presence of Reed-Sternberg cells, which we think are these kind of mutated B cells that cause lots of local inflammation. But we ended with chest X-ray findings of a mediastinal mass and featured our favorite 4T schema: thymoma, thyroid, teratoma, and terrible lymphoma, which of course, the last one it was. Thanks, everybody.
Oh, wow. You're like, I feel like I would just want to bathe in meditation with your voice. Thank you for meditating us through this incredible case. All right, y'all. Hope to see you next time. We're back with RLR. Hopefully Reza can make it tomorrow. He is back from Geneva. We're excited to have him back and hope to see you then. Bye.
Bye.